Okay, thanks for reminding me. I tend to forget actually every time. Who told this one to me today?
Sir Manvi.
Okay, thanks. Okay, so now tumors of kidney we can classify into benign type and malignant type. So under benign, the important ones are adenoma, because the tubules basically they are columnar lining, and if any benign tumor arises from that, so it will be adenoma. Okay, so adenoma means arising from columnar epithelial cells. So adenoma, fibroma, especially if it is arising from interstitial stroma, and another important is angiomyolipoma. So this is also a typical or important benign tumor from kidney, which consists of angiomyolipoma, means there is a vascular component, muscle component, and a adipose tissue component or fat component. So angiomyolipoma. Other than these, actually there are many other benign tumors, and similarly many malignant tumors are there, but for you at your level you just remember this much only. Okay, and under malignant tumor, two things are there in your syllabus. One is renal cell carcinoma and another is Wilms tumor. So we don't have to discuss about the benign tumors. There, as I said, that later on when we'll be studying further at higher level in clinical side, or even later on in postgraduates, so you'll come to know about there are a lot of other tumors in kidney, but these are the important ones at your level. So among them also you have to know only detail about renal cell carcinoma and Wilms tumor. Both of these are very, very important. It is there in your practical, in gross as well as in slide, and it is asked in Viva also. It comes in theory also. Okay, so these two are very, very important at every level. It is asked. As I said, it is in theory also, Viva also, practical also. And in practical there will be gross and slide or microscopy, both are there. Till now actually in practical we are just revising the first year practicals. So after that is finished, we will start with the regular practicals. Okay, at that time we will be doing all the gross and microscopy, etc. But as I said, the booklet which I uploaded, actually that is the urine tests. So that urine test you read, because MCQs will be there from that. Again I am repeating that whatever we have said, the physical examination, chemical examination, all these may be included in the MCQ question paper, in which you have to appear next week, or maybe this week only. Let us see, maybe on Wednesday, or it may be on Sunday. Okay with all of you? Got it right?
Yes, sir.
Okay, some more sound other than Manvi's. Okay. So please read that. Any of you have read that one? Any of you have read the practical notebook? I think nobody has read actually. Please read. And do you in biochemistry they have discussed about those practical tests or not yet?
Not yet, sir.
Not yet. Okay. Okay. Do you think that I should discuss once about those things? At least the important points I'll highlight required, or you will read on your own? Only few things are there.
Yes, sir.
What? Yes, sir, is which one? You will be reading on your own, or I should discuss?
So you discuss it.
Okay. Any more? Any other persons? What is the overall consensus?
Yes, sir. Discuss,
Okay.
Yes, sir, discuss.
Okay, then what I'll do is in the next class I'll do bladder lesions, and after that either I'll be discussing that practical notebook part, or I'll discuss some other questions and all, or I'll revise the whole system once again. Let me see how it goes, and then I'll just let you know. Next class means tomorrow, and Wednesday also. I think once I'll discuss the any important topic you think we should discuss, or I'll do the MCQ on Wednesday. Otherwise, I can discuss the important topics once again, and we can do MCQ on Sunday. Whatever you say. Anyway, you can decide among yourselves and let me know also. Okay. Whether you want any further discussion of any other topic in the renal system. If you don't want, then we can have the MCQ on Wednesday, or if you want some more time for study and some more discussion, or at least I can highlight what are the important points once again. After that, we can have the MCQ on Sunday. You all decide and let me know. Okay, fine.
Yes, sir.
Okay, okay. Then I'll start with, or I'll continue with today's class, and that is renal cell carcinoma. So, as we say, the name is renal cell carcinoma, but actually it is arising from the tubules, okay? Not from the glomerulus or blood vessels or interstitium. It arises from the tubules. So, the other name is adenocarcinoma of kidney, because the tubule is lined by columnar cells. So whatever carcinoma will be arising from that will be some adenocarcinoma. Okay, so though usually we don't use the word adenocarcinoma of kidney much, but it is actually adenocarcinoma of kidney. Commonly we use the term renal cell carcinoma. And there is another name which is hypernephroma, and this is somewhat misnomer, should not be used. It was an old term, and still you should know. Sometimes in Viva somebody may ask that what is hypernephroma and why it is called hypernephroma. That I'll come to later on. Okay, now we will come to the epidemiology. In the epidemiology, it is seen like other malignancies. It is seen in older people. The usual age is 50 to 70 years. Males are affected more, and most are sporadic. That means they are non-familial. That means not hereditary. Okay, but some may be familial or hereditary. That means, say for example, if some person gets renal cell carcinoma, there is less chance that his son or daughter will get renal cell carcinoma, but occasionally that may happen. And under risk factors, these risk factors are important. Smoking, this you have to remember, okay? Smoking, obesity, hypertension, exposure to asbestos and heavy metals, and suffering from chronic renal failure for a long period of time. So these may lead to renal cell carcinoma. Interesting thing is, smoking and exposure to asbestos is also seen in lung carcinoma, and it is seen in renal cell carcinoma as well, because these harmful products of smoking and exposure to asbestos, when a person inhales the asbestos, so all these excretory products will be passing through urine, and kidney will be exposed, and that's why kidney gets the injury of these toxic products. Okay, so I'm just repeating once again: smoking, obesity, hypertension, asbestos and heavy metal exposure, and long-term suffering from chronic renal failure. Now we'll come to what are the different major types. This you have to remember once again. Most important is that clear cell carcinoma. This is the most important, and it is asked especially in the Viva and practical, as well as in the theory also. This is the most important one. In the practical, in the slide what we'll be seeing later on, microscopy, and when we'll be doing practical online, then also we'll be showing you pictures of this clear cell carcinoma only. So this is the most important one. So important one and the most common one. So 80% of all renal cell carcinomas are of this type, clear cell carcinoma. And as I said, this is the most important and most common one. The other two types, the second one is papillary carcinoma, 15%, and the least common type is chromophobe carcinoma. You can call this chromophobe or chromophobic, both are okay. Okay, we can say just chromophobe carcinoma or chromophobic carcinoma. Chromophobe means what? Chromo means anyone?
Color.
Chromo is color. Okay, and phobic means phobic or phobe. This word comes from phobia, means not liking basically. Okay, so disliking. So basically, in this malignancy, the cells of the malignant cells will not take proper stain. That's why it is known as chromophobic or chromophobe carcinoma. In papillary carcinoma, as the name suggests, that there will be papillae formation. So cells will be malignant cells, they will form papillae. Okay, and in clear cell, the cells will be clear in appearance. Okay, so I'm just repeating once again, clear cell, that is the most common type, 80%, most important also. And second one is 15% of RCC, that is papillary carcinoma, and the last one comprise of 5% only, and that is chromophobe or chromophobic carcinoma. So we'll come to gross and microscopy. So first thing is, what is the site of renal cell carcinoma? Most common in poles, and upper pole is involved more than lower pole. Earlier in one disease, in medical disease, we have seen earlier that which appears mostly in pole. Do you remember which one is that? Any of you?
UTI.
UTI, okay, something more specific you have to say. UTI is a more generalized term, you know. Any infection is UTI.
Intrarenal reflux.
Tell once again.
So intrarenal reflux.
Intrarenal reflux, and that will lead to what? Intrarenal reflux is correct. That will lead to what?
Pyelonephritis.
Yeah, which type? Acute or chronic? More important is which one? Pyelonephritis, correct. Pyelonephritis, which one? Acute or chronic? Which is more related with intrarenal reflux?
Chronic.
Chronic is more important actually, and that is more related with intrarenal reflux, and that's why grossly what we can see? Grossly there will be scarring, and that scarring will be more in the upper pole and lower pole, right? So here also I just discussed about it, but anyway, here the tumor will be more in upper pole or lower pole, and upper pole is more common. That also is important. Okay, it is sometimes asked in viva, which pole is more important. Now depending on the type, the gross appearance will be a bit different. Most important is the clear cell carcinoma, and you must remember the clear cell carcinoma gross appearance. So it is a spherical solid mass at upper pole, mostly in the upper pole, and the surface will be bright yellow to gray white, but there will be different areas of necrosis and hemorrhage because it is malignant tumor, and different areas will be different. So bright yellow to gray white cut surface, and there will be areas of ischemic necrosis, that will be gray white, and areas of hemorrhage, that will be reddish to dark brown, and margin will be usually sharp. Usually the margin is sharp. Say for example, here can you see the mass? Can you make out the mass here? All of you? This is the mass, okay? This is the mass, okay? Here you see somewhat little bit tan white or yellowish. It is yellowish to tan, like that kind of color, okay? So in the upper pole there is solitary mass, okay, and the cut surface is bright yellow to, as we said, bright yellow to gray white, and there may be areas of necrosis. Usually in tumor that will be ischemic necrosis, because it will be enlarging quickly, fast, and that's why there will be ischemia in the center of the tumor. So there will be ischemic necrosis. What is the other name of ischemic necrosis? Any of you? Coagulative necrosis. Okay, so ischemic necrosis is same as coagulative necrosis, and also there may be areas of hemorrhage. The margin is usually sharp. Now next is papillary carcinoma. Papillary carcinoma may be bilateral. Okay, so this is again one interesting point, and as they're forming papillae, so that papillae will be within a cyst. Okay, so that papillae will be projecting within a cyst, and that's why often the tumor will be cystic. It will be a cystic mass with hemorrhage inside, and there will be papillary formation within the cyst. So that's why remember the papillary carcinoma may be often cystic, and the cyst may contain hemorrhage, and the tumors will be forming from the lining of the cyst. They will be forming papillae. The third is chromophobe carcinoma or chromophobic carcinoma, and this has typical tan brown cut surface. So this is typical. This word again is a specific somewhat. It is a bit characteristic for chromophobe carcinoma, that is tan brown, somewhat homogeneous cut surface. In this, hemorrhage will be maybe there or may not be there. It is more like tan brown cut surface. Okay. So now another thing is, one characteristic feature of renal cell carcinoma is it may show invasion into inferior vena cava. So interestingly, first thing I'll tell you that invasion and metastasis is different. What is the difference between metastasis and invasion? What is metastasis? Any of you?
Dislodgement of the tumors in the distant.
Distant. Okay, distant, and there should not be any connection between the original tumor and the metastatic site. Okay, so it will be a totally different foci without any connection. But invasion means there has to be connection. The tumor itself is propagating or invading into surrounding tissue. So interestingly, in renal cell carcinoma, these tumor cells will form a solid column and go into renal vein direct with continuation. Okay, not separately from the primary tumor. It invades into renal vein, and that it goes to inferior vena cava, and it may go up in the renal in the inferior vena cava. It will go up to the right side of the heart. Okay, so it may form a long column invading into renal vein, then inferior vena cava, and then even up to the right side of heart. So this is quite characteristic feature of renal cell carcinoma. We don't see this kind of long invasion to distant site in any other tumor. And even if when it is going into the right side of heart, then also the connection from the primary tumor will be maintained. Okay, it can also cause distant metastasis, but this kind of invasion is quite characteristic of renal cell carcinoma. Now we'll come to the morphology part. In the morphology, again, the three types will be a bit different. Most important is the first one, as we said, clear cell carcinoma. Clear cell carcinoma consists of how much percentage? Any of you?
80%.
80%. Okay. And here, as we said, it is adenocarcinoma. So these tumor cells will form solid pattern or trabecular pattern or tubular pattern or acinar pattern. Okay. So these are all different patterns of adenocarcinoma. So solid, trabecular, tubular, or acinar. These are the different arrangement of the tumor cells. And the tumor cell description again is important. So as we call it clear cell carcinoma, so they have abundant clear cytoplasm. The tumor cells are round or polygonal shaped and they have abundant clear cytoplasm. And this clarity or this clear cytoplasm, it becomes clear because it contains glycogen or lipid. So let us see a picture here. So clear cell carcinoma, you see all these are the tumor cells and they are forming these round clusters. Okay, so they are basically forming tubules. Okay, tubules like this you can make out, right? And all this you can see the nucleus, but cytoplasm is all clear cytoplasm, and that clarity of the cytoplasm is due to deposition of what? Any of you?
Glycogen and lipid.
Glycogen and lipid. Okay, very good. So round or polygonal tumor cells, abundant clear cytoplasm. Not only clear, the cytoplasm will be abundant, as you saw in the picture, abundant clear cytoplasm, and cytoplasm contains glycogen or lipid. And these cells will form solid pattern or trabecular pattern or tubular pattern or acinar pattern. Now, next type is papillary carcinoma. As we can make out from the name, papillary carcinoma, so tumor cells will form papillae. Papillae means there will be a central fibrovascular core and around that tumor cells will be arranged. Grossly, how it will be? Grossly papillary carcinoma, how we said? There will be papillary formation. So tumor will be how? In the papillary formations will be
it will be bilateral, cystic,
and cystic. Okay, cystic, and often that cyst may contain hemorrhage. So you remember it will be cystic. That is the important word. Okay, in kidney, if you see a tumor with cyst formation or cystic tumor, that means mostly it is a papillary carcinoma. Okay, and this other also may have some necrotic areas and all, but typically cystic will be papillary carcinoma. Next is chromophobe carcinoma or chromophobic carcinoma, whatever you call it. So here, as the name says, chromophobe means the cytoplasm will not take staining properly. So tumor cells will be pale eosinophilic because it doesn't take the stain properly. It will be pale and eosinophilic. So this one already we saw. This is clear cell carcinoma. Okay. Or you can say clear cell variant or clear cell type of renal cell carcinoma. Whatever you say is correct. Okay, this is papillary carcinoma. Here you see they are forming clusters, but in the center there will be fibrovascular core vessels will be there in the center. So these are all cut section or cross section of papillae. Okay, this kind. Okay, and here this is chromophobe carcinoma. Here basically the cells will not take stain properly. Okay, so this is called chromophobe carcinoma. Anyway, you don't have to recognize these under microscopy, but you have to know the clear cell carcinoma because this is there in your microscopy in the practical. Now we'll come to why it is called hypernephroma. Okay, earlier we said that another name is hypernephroma. That is because one thing is that due to yellowish cut surface and clear tumor cell, the cut surface is yellowish and the tumor cells are clear. So this clear cell carcinoma resembles adrenal cortex. So previously in the past, originally it was thought that they are arising from adrenal, and that's why the name came as hypernephroma. It is actually a misnomer. In older days it was called as hypernephroma. These days this name is obsolete, not used, but still sometimes some examiner may ask in the viva that what is hypernephroma and why it is called hypernephroma. That is because the cut surface is yellowish, that is somewhat like adrenal tumor, and the tumor cells are clear, and that also looks like adrenal cortex cells. Now, what are the clinical features? Under clinical feature, classical triad, these three triad you have to remember. This is again important. Painless hematuria, dull flank pain. Okay, dull flank pain. Dull means vague. Okay, when we say colic, colicky pain or colic means spasmodic, sharp, acute pain. Here it will be dull flank pain, means the pain will be in the flank which is dull, not sharp. Okay, in renal stone we saw that there will be colic. So colic will be sharp pain. It is dull pain in renal cell carcinoma, and there will be a palpable abdominal mass. Okay, the kidney will be enlarged and we can palpate, we can feel the mass from the abdomen by palpation. So these three are again important: painless hematuria, dull flank pain, and palpable abdominal mass. Second is, in any malignancies in body, there may be some fever and weight loss. These are non-specific features, and other than these symptoms, there may be paraneoplastic syndrome. Okay, this again is important. You know what is paraneoplastic syndrome? Any of you? What is paraneoplastic syndrome? Any of you have heard of this word? You can hear me, right?
Yes, sir.
Okay. You know anyone? No, nobody knows. Okay. Paraneoplastic syndrome means even if you don't know, you respond at least that you don't know, okay, or no, or something like that, because otherwise here this is online class. No, if there is no response at all, then I feel that there is some connection problem. If you don't know, you tell that you don't know. At least response will be there. So paraneoplastic syndrome is seen in any malignancy, or especially in lung carcinoma it is very, very important, and renal cell carcinoma it is important. What happens is the malignant tumor secretes some hormone like substances. Okay, and sometimes these substances may have several systemic effect like hormone or some other metabolic effect. So that is known as paraneoplastic syndrome. Okay, so here the tumor cells release some substances. Especially it is important in lung carcinoma, renal cell carcinoma, and it may be there in other malignancies also. So we'll come to paraneoplastic syndrome. These also are important, especially in renal cell carcinoma, you have to remember. So what is paraneoplastic syndrome? This is some metabolic changes or metabolic effect due to production of hormone like substances by the tumor or by the body from other organs also, but it happens because of the malignancy. First and foremost is polycythemia, because here kidney will be producing more erythropoietin, that's why there will be polycythemia. There also may be hypertension, hypercalcemia means increased calcium level, Cushing syndrome. Cushing syndrome is what, you know, any of you? Cushing syndrome is increased ACTH level. Okay, increased ACTH level or adrenocorticotrophic hormone. Okay, we will be discussing these things about Cushing syndrome and all in endocrinology once again, but at least I expected this you must be knowing, because it is in +2 only it is taught that Cushing syndrome is increased adrenocorticotrophic hormone. And also there can be feminization or masculinization. Say for example, some female getting hirsutism. You know what is hirsutism? Yes? No response at all. You can hear me, right?
Yes, sir.
Yes, sir.
Okay. So hirsutism means there will be increased facial hair, okay, like beard and all. So if a girl is having more or a female, say for example elderly especially, they are having increased that is masculinization. So feminization is on the other hand. I'm sorry, I'm just saying opposite. Feminization is if there is gynecomastia in a male. Okay, so that is feminization, and masculinization is if there is hirsutism in female. So that can happen because of some female sex hormone release in male and vice versa. So feminization is when there is gynecomastia in male, and masculinization is when there is hirsutism or increased facial hair in females. So that can happen in renal cell carcinoma, and amyloidosis is another point. So these are again important: polycythemia, hypertension, hypercalcemia, Cushing syndrome, feminization or masculinization, and amyloidosis. And RCC overall, it can metastasize widely throughout the body. It can go to anywhere, including lungs, bones, even CNS, anywhere it can go. Okay, and treatment is nephrectomy. After that, if there is wide metastasis, we have to give chemotherapy. So till now, okay with all of you?
Yes.
Yes, sir.
Okay. Okay, then I'll go to the next one. That is Wilms tumor or nephroblastoma. This again is very, very important. It often comes as a short note. So this is the commonest primary renal tumor of childhood. Okay, this is malignant tumor, but it is seen in children. Don't get confused between these two. In exam, many of you say that I'll just tell you what you say. Okay, so interesting thing is this is a malignant tumor, but it is seen in children. So in exam, either you say malignant tumor in adult or you say benign tumor in children. Okay, interesting thing is it is a malignant tumor, but it is seen in children, so that you don't get confused. In the name, there is no carcinoma word is not there. Okay, Wilms tumor and other name is nephroblastoma. So though the name is OMA, but it is malignant tumor. So this part again I am repeating, don't get confused or foxed during exam time. Name is blastoma, but it is actually a malignant tumor. And though it is malignant, it is seen in children. And though it is malignant, the prognosis is excellent. So these points are important, and often during exam you get confused about it. So Wilms tumor or nephroblastoma. So as the name suggests, it arises from nephroblast or primitive kidney cells or primitive renal cells. So that's why name is nephroblastoma. And Wilms tumor, the name came because it was discovered by Dr. Wilms. That's why the name came as Wilms tumor. So this is the commonest primary renal tumor of childhood, first described by Dr. Wilms or Max Wilms. Age group is children. Okay, before they go to school actually. Most is 2 to 5 years. It can happen till 10 years, but the most common age group is 2 to 5 years. And though it is malignant, the prognosis is excellent. And here we can see typical some defect will be there in a gene that is known as WT gene. WT stands for Wilms tumor. So Wilms tumor gene, which is situated in chromosome 11. So all these points are important. Again, I am repeating, this is nephroblastoma or Wilms tumor. In the name, malignant word is not there or carcinoma word is not there, but this is a malignant tumor. And though it is malignant, it happens in children and the prognosis is excellent. Okay, age group is 2 to 5 years, and it has some genetic implication or genetic in the risk factor. Genetic mutation is important. So the gene which is affected is WT gene or Wilms tumor gene, which is situated on chromosome 11. Any of you can tell me which is the gene defect in adult polycystic kidney disease?
TKD1.
16.
Yeah, chromosome
16.
16 and gene is PKD gene. Here it is WT gene. Easy to remember the name. PKD comes from polycystic kidney disease and WT from Wilms tumor. But you remember the chromosome number also. Okay. Fine. Here it is 11. There that is 16, and it is associated with 3 syndromes. So this is often asked, and this you have to remember in toto. Full all the components you have to remember. You have to mug it up actually, because this is asked repeatedly at every level. Okay, so there are other syndromes also, but 3 syndromes are important for you. First is Weger syndrome. Okay, Weger stands for WAGR, Wilms tumor. A is aniridia or absence of iris. G is genital abnormality, and R is retardation, that is mental retardation, not growth retardation, that is mental retardation. Remember that. It's Wilms tumor, aniridia, genital abnormality, and mental retardation. Okay. Next is another syndrome is Dennis-Drash syndrome. Dennis-Drash. Okay, name you have to remember, and not only the name, spelling you have to remember. Okay, Dennis-Drash. And here there will be gonadal dysgenesis, renal failure, and Wilms tumor. So this is relatively easy to remember. Gonadal dysgenesis. Exactly this word you have to remember. Okay, gonadal dysgenesis, renal failure, and Wilms tumor. And third one is a big long name, that is Beckwith-Wiedemann syndrome. Beckwith-Wiedemann. The name Wiedemann is German name, so spelling is important. W-I-E-D-E. Okay, Wiedemann and double N. Okay, Wiedemann. So this spelling you remember. Okay, Beckwith-Wiedemann syndrome. So here you remember that as the name is large, so the features also will be something with enlargement. Okay, so the name is large, so the features also will be something enlargement or large size like that. Okay, remember in that way. So first point is enlargement of body organ. Second is hemihypertrophy, means one side of the body will be larger than the other side of the body. Okay, in a baby, if you one side of the body will be larger than the other side of the body, that is hemihypertrophy. Renal cyst and large cells in adrenal cortex. Here also the word large is there, and obviously the last is Wilms tumor. So everything is something with large. Okay, Beckwith-Wiedemann syndrome, this is the longest name, the largest name. So there will be enlargement of body organ. Hemihypertrophy, half of the body will be enlarged. Renal cyst, large cell in adrenal cortex, and Wilms tumor. So this is okay with all of you. I'll proceed. Yes?
Yes.
Okay. So morphology. So gross and microscopy, again this is very, very important. Gross, solitary lesion, well circumscribed lesion. Here important thing is, in renal cell carcinoma we saw that there can be hemorrhage and necrosis, but usually in this Wilms tumor we don't see much hemorrhage and necrosis. So it will be soft, homogeneous, and gray. Soft, homogeneous, and gray. Homogeneous means that there will not be much necrosis and hemorrhage. So that's why it is homogeneous. So see, this is a large tumor in the kidney. Okay, and this is Wilms tumor. Here we don't see much necrosis and hemorrhage. Okay, so this you have to remember. Hemorrhage and necrosis will be more in renal cell carcinoma and less in Wilms tumor. Now we'll come to the morphology. This again is very, very important. Now this first line you have to remember as it is, that there will be attempts to recapitulate nephrogenesis. Okay, what does it mean? It means that the tumor cells will try to look like when there is nephrogenesis. Nephrogenesis means when the kidney is being developed in the fetal life. So it will look something like fetal kidney. Okay, so the tumor cells will try to recapitulate, means to look same, okay, or somewhat resembling. Okay, so recapitulate. Nephrogenesis means the fetal kidney. When the kidney is being formed in fetal life, it will look like that. Okay, so it will look like fetal kidney. So this is the classical description. So this you remember, the tumor cells will show attempts to recapitulate nephrogenesis. And here there will be 3 different types of cells. This you have to remember. One is blastomemal cell, stromal cell, and epithelial cells. Blastomemal cells are tightly packed blue cells. Why we are calling it blue? Because in blastomemal cells the cytoplasm will be less and the whole cells will be occupied by the nucleus. So they are blue cells. Stromal cells will be elongated cells or fibrocytic cells, and epithelial cells will form tubules. So we'll see a picture once. Here these cells are blastomemal cells. You see here these areas are bluish cells, small cells, and they are round blue cells. Okay, their look is blue because these cells are occupied mostly by the nucleus. That's why these cells are blue cells. So these cells are primitive immature cells, and that's why they are called as blastomemal cells. Second is stromal cells. This area is stromal cells. Here you see elongated cells, and these cells are fibrocytic cells. Okay, so we are calling it as elongated fibrocytic cell and stromal component. So blastomemal component, stromal component, and third is epithelial component. So epithelial component, these are the epithelial cells which will form some abortive tubule. Okay, so these epithelial cells will form some tubules which are mostly abortive tubule. Abortive tubule means these tubules are not properly functioning or not connected. So they are forming, but it is not, formation is not complete. So we call it abortive tubule. Okay, I'll write the word here actually. Okay, so blastomemal cells, stromal cells, and epithelial cells. Is it okay with all of you? Clear? Yes, all of you okay, right? Blastomemal, stromal, epithelial. This you have to remember. Okay. And last slide today is what are the clinical features. So here we'll see children with large abdominal mass, and treatment is nephrectomy and chemotherapy. Prognosis, as we said, excellent prognosis. Now we are having good chemotherapy, and usually these children will have long-term survival. More than 90% will survive for long period. So prognosis is good. Okay. So just to repeat once again, what are the important points? First thing is, it is the commonest primary renal tumor of childhood. It was described first by Dr. Wilms, and though the name is Wilms tumor or nephroblastoma, in the name there is no malignant word or carcinoma, but it is the malignant tumor in the childhood, okay, in the child life. So this is the malignant tumor of children, and though it is malignant, the prognosis is excellent. Defective chromosome is chromosome 11, which contains WT gene, and 3 syndromes: Weiger, Dennis-Drash, and Beckwith-Whiteman. In Weiger, the name is WAGR, so Wilms tumor, aniridia, genital abnormality, and mental retardation. Exactly, you have to remember that way. Okay, genital, don't write gonadal or some other thing. Okay, genital abnormality or urogenital abnormality. Retardation is also not growth retardation, it is mental retardation. Dennis-Drash syndrome, gonadal dysgenesis, renal failure, and Wilms tumor. Beckwith-Whiteman, as I said, everything will be enlarged. So remember in that way. Okay, don't write that, but remember that name is long, so there will be enlargement of body organs. Half of the body will be larger, so hemihypertrophy. Kidney will have renal cyst, large cells in adrenal cortex, and Wilms tumor. Morphology, solitary tumor will circumscribed, and most important thing is cut surface is homogeneous. We don't see any hemorrhage or necrosis. And under morphology, first thing is the tumor cells show attempts to recapitulate nephrogenesis. This line, though sounds little difficult to remember, but you have to remember this language. And 3 types of cells, that's why we are calling it as triphasic tumor. 3 types of cells: blastomemal cells, stromal cells, epithelial cells. Blastomemal cells will be tightly packed blue cells because the cells are occupied by the nucleus. Next is stromal cells, the elongated fibrocytic cells, and epithelial cells. So they will form abortive tubules. And last is, in the clinical feature, there will be large abdominal mass. Treatment is nephrectomy and chemotherapy, and prognosis is very good. Long-term survival is 90%. Okay with all of you?
Yes, sir.
Okay, then today I'll close, right? Okay. Okay, then thank you. In between, you just discuss among yourselves also. If there is any other topic or any specific topic you want me to repeat, then I'll repeat, right? You let me know in between, right? Okay, okay, okay.
Sir,
yes?
so you haven't uploaded the slides from the last class, sir?
Okay, okay. I didn't put up. Huh? Okay, okay. Then I'll do. Okay, okay. I'll put it up. Okay, okay.
Thank you, sir.
Okay, okay.